Okay, this next segment that we'll talk about is on placenta previa. Placenta previa occurs in about half of pregnancies at term. In the news, there has been a report of Princess Kiko from Japan going to have a baby. What is interesting is she did, in fact, give birth to a male heir, which was the first male heir in a whole generation. But this lady, Princess Kiko, was delivered by a cesarean section. Why was she delivered by a cesarean section? Because placenta previa. Placenta previa is not a respecter of persons. It can occur in royalty as well as in the common person. 34-year-old multigravida, 31 weeks gestation, comes to the birthing unit, stating she woke up in the middle of the night in a pool of blood, but no pain. No pain. Painless bleeding. What do you think of? Placenta previa. No pain, no contractions. Interestingly, inspection of the uterus shows the fetus is transverse lie. It should be longitudinal lie. Why is it transverse lie? One of the causes of transverse lie, particularly in the last part of the pregnancy, is if the pelvic inlet is covered by the placenta, the fetus cannot engage and assume its normal posture. Whenever you have a third trimester fetus in transverse lie, consider either a fetal anomaly, a uterine anomaly, or placenta previa. Fetal heart tones are regular, 145 a minute, which is in the normal range, and she has bloody perineum. All right. The character of the bleeding, painless or painful? Painless bleeding. When you have on the exam, third trimester bleeding, painless, remember, placenta previa. Late trimester bleeding, low segment placental implantation, no pain, that is consistent with placenta previa. And that can be identified by ultrasound. Now, when we see placenta previa early in pregnancy, first trimester, second trimester, it's quite common. And yet, by the time term comes around, the placenta appears to have moved. The term that we use is placental migration. Do you think the placenta really gets legs and walks away? No. What probably occurs here is there is differential atrophy and hypertrophy, which moves, quote unquote, the placenta away from the lower segment. Up to 20% of placentas will be in the lower uterine segment early in pregnancy. Only 0.5% at term. The difference, trophotropism. Tropho, placenta, tropism, movement. Movement of the placenta. Here we have an early pregnancy, and you can see that the placenta comes down almost to the cervical os. It is in the lower uterine segment. What happens? Here's what happens. Notice the placenta is low over time. The lower part of the placenta will atrophy. The upper part will hypertrophy. This may be because the blood supply to the placenta comes from the lateral wall of the uterus, and we have less optimal blood supply in the lower segment. This can even retract further as we have atrophy down here and hypertrophy here. And this is then probably the mechanism of placental migration. Atrophy in the lower segment and hypertrophy in the upper segment. So I don't even tell patients that they have a placenta previa early in pregnancy. I just say we're going to repeat the ultrasound to make sure that the placenta is where it should be. The pathophysiology of bleeding is avulsion of the anchoring villi from stretching of the lower uterine segment. This is the lower uterine segment. And if the placenta is attached down here, as it stretches with the effacement which occurs in the latter part of the pregnancy, you're going to have bleeding. Why don't we have bleeding from placenta previa in the first trimester? Why don't we typically have in the second trimester? Because that lower uterine segment has not formed. The formation of the lower uterine segment is typically in the last part of the pregnancy. We can have a variety of different kinds of placenta previa. We can have a low-lying, a partial, or a total central. Let's look at what those look like. Here we have a drawing that I made of the uterus. And remember, we talked about where the placenta could be. It could be fundus, it could be anterior, posterior, lateral walls. The main thing to remember here is it is not in the lower uterine segment. Here we have a marginal placenta previa. You can see it comes down low in the lower segment. It is not at the cervical os, but it is close to it. If there is bleeding, is this mother's or baby's blood? Maternal blood. Keep that in mind because we're going to come back to that in just a minute. It's quite possible that this part of the placenta could very well atrophy, this part hypertrophy, and this patient could have a vaginal delivery. A partial placenta previa, you can see the placenta comes down to the cervix, not quite over it, but almost. Again, this is going to be whose blood? Mother's or baby's? Mother's blood. What's the blood volume of a pregnant woman? Non-pregnant woman, about 5 liters. Pregnant woman, we increase the blood volume by 50%. So she's got 7.5 liters of blood. What if she loses 300 cc's of blood? Any big problem? No, she can usually handle that just fine. This placenta may retract or may not. How about this one? This placenta completely covers the cervix. This one is also maternal blood, and this one's not going to go away. This is going to be, for sure, a cesarean delivery. So here we have a normal implantation. Here we have a low implantation, a partial placenta previa, and here we have a total placenta previa. And this baby is wondering, what the heck am I going to do? Total placenta previa. Risk factors. Remember we talked about getting an obstetrical history? If she had a previous placenta previa, likelihood that it could happen again. So that's going to be important. Multiple gestation. Twins and triplets. The more placentas there are in the uterus, the more likely one or more of those is going to be down in the lower segment. So previous placenta previa, multiple pregnancy is a risk factor. What's interesting is that artificial reproductive techniques, ART, increase the risk of placenta previa. Why is that? And here's the reason why. Artificial reproduction involving with IVF, in vitro fertilization, and embryo transfer. Normally, where does implantation occur? It occurs in the fallopian tubes, and we have the zygote, which becomes then the morula, comes into the uterine cavity at the top. How are you going to put an embryo in the uterus with IVF? It's going to have to be through the cervix. And initially, what often happened was the embryos would be put through the cervix and they would implant in the lower segment, which then, of course, is going to increase the risk. So nowadays, when the infertility specialists put the embryos in the uterus, they're careful to put them as high as possible to try to minimize the chance of placenta previa. And that is a concern. How do we manage placenta previa? You can see we have a variety of options: emergency cesarean, conservative in-hospital management, vaginal delivery, or a scheduled cesarean. Anytime you have maternal or fetal jeopardy, tachycardia, hypotension of the mom, or repetitive late decelerations, bradycardia of the fetus, you've got to get this baby out. Pronto. Quick. Vite. Don't wait around. Okay, let's say a patient comes in. She's 30 weeks, painless bleeding, which is now slowing down. Ultrasound confirms that there is a placenta previa, but she's stable. You can deliver her at 30 weeks? No. We're going to just park her in the hospital, give time for the fetus to mature, going to give her betamethasone to mature the fetal lungs, and watch. If the cervix and the placenta are more than 2 centimeters apart, so it's a low implantation, she may actually be able to have a vaginal delivery. This would be, remember, placenta previa does not mean over the cervix only. Anywhere in the lower segment is a placenta previa. And here's a marginal placenta, which could be a vaginal delivery. The last is a scheduled cesarean. And here's a patient who's been in the hospital for, say, 6 weeks. She is now 36, 37 weeks. She is stable. Mom and baby are doing well. We do an amniocentesis. We confirm that there is fetal lung maturity. And she's got a total central placenta previa. Management, scheduled cesarean. So, whether we have a normal placental implantation, marginal, partial, or total, all of these are going to impact on what we do in terms of management. And the clinical situation will determine that. This is an ultrasound, and you can see this is the internal cervical os. This is the external cervical os. Here is the fetal head, and there is no placenta here. This is a normal appearing cervix. It is 30 millimeters long, no placenta previa. Now compare that with the next picture. Let me see if I can make this a little clearer for you. Here's the bladder. This is the cervix. This is the internal os. This is the external os. Here is the placenta. And you can see the placenta extends down toward, but not quite to the internal cervical os. This would be a marginal or low-lying placenta, and this may very well atrophy down here, and she may have a vaginal delivery or may not. We'll just have to check and see. Compare this with the next one. This is the cervix, internal os, external os, and here is the placenta. What's the likelihood that this one will retract? 0. This is almost certainly going to be a cesarean delivery. And this patient may very well be hospitalized for a prolonged period of time. And that brings us to the end of placenta previa.